I'm Dr. Tenley Murphy. I'm with the University School of Medicine. I'm in the Department of Orthopedics and Family Medicine. I run the Sports Medicine Fellowship and serve as one of the team physicians there. I have no disclosures. The objectives are in your handout. I came to exercise and pregnancy not straight out of med school and residency. I would say I kind of shied away from anything OB related during my family medicine residency. It wasn't until a lot of my athletes started coming to me my first few years in practice, and then 7 years ago when I became pregnant, I realized I had a lot of questions that my OB practice was not able to answer for me. I often found my surrounding support system was more judgmental than encouraging, and weren't actively trying to help me achieve my goals and help me have a healthy pregnancy. So I started doing a lot of research on my own. I will warn, the one thing I did learn is whatever we do during pregnancy apparently carries over once your child is born, because I now have a child who runs everywhere. I ran the day I delivered, the day I went into labor. It was the last morning I ran until a couple weeks postpartum. So it can be done. If nothing else, take away from this the ability to encourage your patients to stay active. This is an epidemic facing not just our pregnant patients, but this lack of physical activity and keeping our patients moving, something we really need to focus on. So what's going on in the world? In the past few years, we've had a marathon runner train her entire pregnancy and go on to win the New York City Marathon 10 months postpartum. If any of you have social media access, you know the world's favorite reality TV family exercises during their pregnancies. But patients are seeing this. They're going to ask about it. So be prepared to answer those questions. Serena Williams, if you guys watched Wimbledon last week, almost won 10 months postpartum, but she won the US Open while she was pregnant. Carrie Walsh won an Olympic gold medal while she was 5 weeks pregnant. So it's okay to move. It's okay to exercise. Unfortunately, we're looking at this dichotomy with our patients. The majority of them are not meeting those exercise goals, those physical activity requirements we want them to get while they're pregnant. And then we have our enthusiastic over-exercisers who we're trying to rein back in a little, but we need to be able to support them and guide them in their journey through their pregnancy as well. So the easiest place to start is first, preconception, and I love the lecture we just had. Healthy lifestyle preconception is going to help them have a healthier pregnancy, but once they become pregnant, there are contraindications to continuing their activity, and they're pretty common sense. Obviously, any significant heart disease where they're hemodynamically unstable, no. Restrictive lung disease, any kind of incompetent cervix or cerclage, multiple gestations that are at risk of preterm labor, persistent second or third trimester bleeding, placenta previa after 26 weeks, premature labor during your current pregnancy, ruptured membranes, development of preeclampsia, and severe anemia. We know going through pregnancy, there's normal physiologic adaptations that everyone's going to face, cardiac, metabolic, your thermoregulatory, your effects on posture, and those nutritional requirements. The great thing is, as you get into maternal exercise, your solid lines on this graph are the expected physical responses to exercise, and your dashed arrows are the adaptations the body will make to accommodate for those effects. So you can see you're going to go into a hemoconcentration to avoid that decreased, the effects of the decreased uterine blood flow. You're going to get placental fetal adaptations using alternate fuels, making sure the baby's still getting what they need. So broadly speaking, if your patient just comes to you and says, "What can I exercise?" Regular low-risk pregnancies, yes. Encourage them. Be their biggest supporter. I was at an Orange Theory workout last week, and the girl next to me was 30 weeks pregnant, and I just wanted to tell her how proud I was of her that she was staying active and doing something. And she gave the same response that I had experienced, is that most people had been very critical of her staying active. They told her she needed to stay home and rest and put her feet up. And I was like, if I can be your supporter, I will be your supporter. It was great to see. So types of exercise that your patients are going to ask about. First one's going to be endurance training, whether it's walking, running, swimming. You look at, there were 2 different studies that looked at this, and obviously it's unethical to test our pregnant patients to failure. So we're not going to have perfect data explaining how much they can do or what their true limits are. But when they looked at highly conditioned athletes in that moderate to high level exercise, they noticed an improvement in their VO2 max during their pregnancy and postpartum. In your recreational athletes, there was no difference in their aerobic fitness. So if they just maintain their activity level, they're going to improve or maintain that aerobic fitness. So we know that the body can adapt to this. What they did look at from a testing standpoint was that VO2 max. And what we did find out is that 90% threshold is when we did start to see some transient fetal bradycardia at that, above that max 90% maternal heart rate. So a great kind of hard and fast guideline would give them is you need to stay below that 90% max maternal heart rate. And I will tell them to wear a chest strap heart rate monitor or a watch or something. They have the bicep bands as well, so they're monitoring it. Target heart rate ranges they're going to look at in your women 20 to 29, that 145 to 160 beats per minute. 30 to 39 years old, that 140 to 156. Some patients or some studies looked at that respiratory exchange rate and then your ratings of perceived exertion, so not actually monitoring your heart rate. And specifically in the 2nd and 3rd trimesters, the mean BPM went up by 16 with a range of 11 to 54, higher than what patients were perceiving. So it's that much more important to explain to your patients, don't go by that perceived exertion. You really do need to be monitoring your heart rate and stay below that 90% max. Using that RPE, you're going to exercising at a higher rate, potentially creating risk. And we have all our athletes measure heart rate directly. So athletes that like to train at altitude, or your patients who are going to be going on vacation to Colorado and say, hey, can I walk while I'm out there? Is that okay? The limited VO2 max exercise testing they did on patients at 33 to 34 weeks, they did it at sea level, and then a week later they sent them to 6,000 feet above sea level. There was some limitations to that maximal aerobic capacity. They didn't report any ominous fetal responses, but there is still that theoretical concern at altitude of decreased blood flow to the uterus from exercise and hypoxia. So the recommendation really would be to stay below 1,500 to 2,000 meters above sea level from an exercise standpoint. The next one I always get asked about is strength training. And for some reason, pregnant women really start to worry about their core. Now's not the time. Focus on that after. Light to moderate weight training isn't going to have an adverse health effect. And what I generally recommend, either seated weights, seated free weights, so they're doing upper body or lower body, but nothing where they're getting into squats, lunges, nothing where they're laying on their back doing direct core work. Obviously not trying to increase that intra-abdominal pressure, but also not putting risk of compression of the blood vessels, and also not putting stress on the abdominal musculature. Not wanting your patients to develop hernias. I actually have a friend who's an elite runner, and she called me 14 weeks pregnant and said, I think I have a hernia. And I asked her, what were you doing? Sit-ups. Don't do it. Say 12 weeks, we got to back off on the core, but it's okay to do that light to moderate, upper or lower extremity strength training. Women who adopted strength training during their pregnancy actually showed really large gains in lean muscle mass and strength for that 12 weeks they participated during the pregnancy, and especially a 14% increase in lumbar endurance. This potentially has the benefit of helping during labor, decreasing low back pain in general during your pregnancy, but also long-term health of low back strength. We looked at training loads comparable to elite athletes or that heavier load. Again, that Valsalva during weight training, it precipitates that rapid increase in blood pressure and that intra-abdominal pressure, so temporarily decreasing the blood flow to the fetus. And there's also a theorized potential harm to the pelvic floor, that risk of urinary or anal incontinence, pelvic organ prolapse. So again, try to steer them away from core exercises. Flexibility training, I love to talk to patients about doing yoga, especially during pregnancy. That relaxin level kicks in. They have improved laxity outside of just physical space around the belly. They tend to benefit. They're going to have to modify this. They don't need to be going to a yoga studio and trying to do the hour and 10-minute class like everybody else. Either seek out videos online or working with the yoga instructor to try and avoid overdoing it or those harmful positions. There really aren't any studies on the pregnant population measuring range of motion, but we can theorize that this improves. Things I want to tell them to avoid: contact and projectile sports. Obviously hockey, basketball, equestrian, but I like to talk about volleyball, pole vaulting, anything where something is coming flying at you, probably best to avoid. And then that physiologic risk where there's acute or chronic fetal hypoxia or placental abruption. So skydiving, scuba diving, and I like to steer them away from that hot yoga where they're increasing that core body temp so significantly. They're not going to do well in that setting. So from a collegiate standpoint, and this is just my baby that we get back to, is the NCAA requires that every university have a policy for pregnancy, so that from a Title IX standpoint, student athletes aren't discriminated against. But it's a team physician decision. My recommendation is generally at 12 weeks, we pull them from contact or projectile sports, and then we help modify their training to keep them involved in their sport to the level that they can. And this is to protect them from coaching staff, athletic department issues, but also keeping them involved in their team and their sport. Now, exercise can benefit a lot of different aspects of pregnancy. Your patients are going to come to you with a lot of clinical issues, whether they're exercisers or not, and these are great opportunities to advise them on why exercising is so beneficial. A lot of patients can reduce the frequency and the severity of their nausea by staying active. The catch-22 to this is nausea symptoms can keep patients from getting up and going and wanting to exercise. So you as providers being able to manage that nausea and helping them get over that hump to get moving and staying active will actually in the long run help decrease those symptoms. Fatigue is another big one that you're going to hear about. And this is a fine balance because over-exercising is going to increase that fatigue factor, but if you help them promote kind of those general physical guidelines that we're looking for, that quantity intensity can actually help avoid that daytime fatigue, help them sleep better at night so they're not as fatigued when they wake up. And then the biggest one for me is this mental well-being. We know pregnancy puts patients at risk for depression, postpartum depression, so getting them moving, keeping them active is giving them a built-in tool to combat that depression that has the potential to develop. So in an effort, you're doing preventative medicine for these patients just by getting them moving. Gestational weight gain, about 50% of our patients are gaining above the IOM recommendations. And there's numerous studies that show a decline from pre-pregnancy levels once they become pregnant. And it's significantly related to higher gestational weight gain. They had a longitudinal cohort study that demonstrated women meeting that 30 minutes per day of activity had almost a 30% lower odds of gaining above those recommendations. So there's significant improvement in patient outcomes if we're helping them achieve just that 30 minutes a day. Mid-pregnancy walking and moderate intensity exercise was inversely associated with the risk of excessive weight gain. Preeclampsia. There's multiple mechanisms that help reduce the risk of preeclampsia associated with exercise that enhance placental growth and vascularity, the reduction of oxidative stress, reduction of inflammation, and then the correction of endothelial dysfunction. The maximum benefit of exercises to help your patients, it needs to be started during that first trimester. I looked at a 2014 meta-analysis that just looked at leisure physical activity, so not going to the gym and getting a ton of minutes in, but just staying that 30 minutes active during the day. Initiating that before 24 weeks was over a 20% reduction. So we know there's a greater benefit for those exercising, and that benefit of 20% goes up even more with a higher intensity. Strenuous exercise prior to pregnancy, so your patients who you helped develop an exercise plan prior to conception, 40% reduction. And we think of this in the terms of how much we're dealing with high-risk patients and chronic illness. Getting them moving before is going to help them during. We also look at hypertension, 2 epidemiologic studies. There's a 70% reduction in gestational hypertension among Hispanic women that were studied. And the RCT demonstrated women who initiated a structured exercise program early in their pregnancy were 3 times more likely to prevent the development of gestational hypertension. Diabetes, which we're in the South, Lord knows we all see it. That lack of physical activity before is obviously a major risk factor. So trying to prevent that obesity, trying to develop the risk factors prior is going to help. But the data's limited on this. It's more what we're kind of anecdotally extrapolating from our patients would suggest that exercisers would be expected to be at a lower risk. The one I get to see all the time, the MSK complaints, I see a lot of SI joint and pelvic girdle pain from these patients and low back pain. Your prevalence is about 50% during pregnancy. Getting them moving, and I'll often get them plugged in with a performance therapist or physical therapist that can also do dry needling, helping them move. Dry needling at the SI joint and the low back is really helpful. It's not giving them a medicine to mask something or make it go away. The theory behind dry needling is you're trying to stimulate inflammatory responders to the area to stimulate healing. And these patients do really well. The pelvic girdle pain, there's a 14% lower risk in exercisers, which is significant. So again, get them moving. Pelvic floor dysfunction, women who exercise more than 3 times per week at up to 37 weeks had a significantly larger levator hiatus area than non-exercisers. The next leap to that is that you're going to have a reduction in pelvic floor dysfunction. There's not great data to support that. That needs to be looked at further. They're just extrapolating from what they're seeing develop. The other thing we worry about from a muscular standpoint is your diastasis recti. Prevalence about 27% in patients, and there weren't really any specific studies looking at exercisers or athletes, but the recommendations for workouts would be, again, to limit that intra-abdominal pressure increase, specifically holding off on abdominal workouts after 12 weeks. Patients also want to know, how is my activity going to affect what's going on inside? How is it going to affect the fetus? Any kind of regular exercise is going to trigger that 10 to 15 beats per minute increase in fetal heart rate. That is known. It's not directly correlated to the intensity of a woman's workout. That's just reflective of that protective mechanism of the fetus. But again, we know that fetal bradycardia was in 3 reported cases with that exertion over 90% of VO2 max. They noted D cells during and immediately postpartum. So we want to monitor that exercise or monitor that exertion during exercise. And this is what I would tell the patients. As long as you're monitoring, as long as you're staying below that max, your risk is low. The risk of miscarriage, light to moderate physical activity, there's no change in your risk level compared to non-exercisers. This is going to be the question I find most patients ask. So they need to let go of that. There's actually early data looking at the decreased risk of miscarriage. Strenuous exercise are greater than 7 hours per week, so you're more elite athletes. They did have an increased risk of early miscarriage. This is assumed to be highest risk at that time of implantation, but after 18 weeks there was no association between miscarriage and that level of exercise. So how is the fetus growing? What is the newborn's weight going to look like? Regular exercisers are associated with that redistribution of blood flow to the skeletal muscles away from splanchnic organs. As you get into the third trimester, the blood flow to the uterus increases from 50 to 500 mLs per minute. So you can imagine that's blood flow that needs to be going to the uterus. The theoretical concern is that regular strenuous exercise may affect redistribution of a portion of this blood flow, impairing fetal growth. However, when we looked at studies, there's a Cochrane review that reported no significant change in birth weight with exercise. We do know that moderate intensity exercise reduces your risk for large for gestational age. So if anything, it actually helps us normalize birth weights as opposed to having these big ends of the spectrum. Strenuous exercisers, your elite athletes, had a lower birth weight of about 200 grams versus non-exercise. And this was reflected more as a lower fat mass. And these babies actually had a greater lean muscle mass as a newborn. But the difference in having a baby less than 2,500 grams was nil, but there was over a 30% lower risk of having a baby greater than 4,000 grams. So you can see how the benefit for the fetus as far as not getting into that larger for gestational age bracket. Preterm birth, these are just observational studies from exercisers. There was no evidence of any association between physical activity and preterm birth. And I do think this is an area that definitely needs more data or very limited studies when I pulled the literature. Now, how can exercise benefit our women as they go into labor? There's moderate evidence that exercise does not increase the rate of induction, episiotomy, or epidural. I think for many years we theorized that exercising regularly created a tighter pelvic floor impeding childbirth. And you would not believe how many people actually told me this, that I was gonna have a hard time delivering because I was working out. That was not the case, but there's no studies that have identified this as an issue. Conversely, women who are exercising potentially have stronger abdominal muscles. This may aid in pushing labor and shortening that second stage of labor. But again, no studies have really looked at this. I think the delivery aspect will be a great opportunity for more research concurrently between OB and sports medicine, because it's amazing how many pregnant patients are coming to sports medicine physicians asking us questions, even though it's not necessarily our area of expertise. Once they've delivered, how do we get them back moving? Most of my athletes, their first question is, when can I go work out? Whether that's post-surgery or post-delivery. So be ready to answer that question. Several studies looked at women's level of participation in exercise before being pregnant and after, and unfortunately the majority of women, that level drops off. My mother-in-law even told me, she's like, you're not gonna be able to work out as much as you do once you have your baby. Let's be a positive voice. Let's be encouraging to the people around us and get them going. Don't let your patients fall off. I recognize having a baby cuts into your time, it cuts into your energy level. Help them figure out how to make it part of their routine. But they can get back into that routine gradually after pregnancy, as soon as medically safe, from a normal vaginal delivery, no complications. If they want to get out walking the first few weeks and then ease back in to running or the higher level intensity exercises. Any medical or surgical complications are going to be obviously more based on how they're healing and giving their bodies time to recover, 6 weeks, 8 weeks after those interventions. Regular exercise obviously after improves that cardiovascular fitness, but it doesn't affect milk production. So your patients who are breastfeeding don't need to stress about how they're gonna have a decrease in production. I do encourage them to consider nursing or pumping prior to working out, just to avoid the discomfort from that breast engorgement, and also encouraging them really that adequate hydration to make sure that they're taking care of themselves and their body's prepared to do both activities. I don't know why I skipped over that. Things to talk to your patients about that they can do: walking, swimming, stationary cycling, low impact aerobics, again, modified yoga, modified Pilates, running or jogging, and that strength training, avoiding that core exercise. Obviously, there's always going to be warning signs, things they need to watch for to determine cessation of activity. Any vaginal bleeding, regular painful contractions, amniotic fluid leakage, shortness of breath before they're supposed to be going to work out. If you're tired and short of breath, don't go work out. Dizziness, headache, chest pain, muscle weakness affecting their balance. If patients physically are getting to a size where they're not comfortable doing certain things or they don't feel safe, help them find an alternative. And obviously any calf pain or swelling. Your patients who want to stay active, there's multiple versions of running belts. These are phenomenal. They help take that weight off your pelvis and support the baby. Again, I ran one of these. It was superbly comfortable, and they're everywhere. Amazon has them for like $19.99. And mine's still running as we're going. So I know that was quick. Again, there's not great data to provide your patients on exercise management. Most of my information was pulled from the series that was in the British Journal of Sports Medicine. They have a 6-part series, and it really pulled all of the data that's there. If this is an area you're interested, I would encourage looking at the opportunity to do some studies, collaborating within specialties to really provide our patients with more information. Thank you.
Got a lot of time for questions. Hey, here we go.
Tenley, did the fact that these women were still, including yourself, were still fit during their pregnancy, or at least more fit than if they were not exercising at all, did it affect the delivery positively?
Absolutely.
I mean, was there less stuff going? I'm a guy. I don't know what stuff's going on in there. But was there less stuff? Episiotomy,
yes.
whatever.
If you look at the medical literature, there was a decrease in episiotomy, a decrease of instrumentation. Anecdotally from my friends who are elite athletes and myself, the pain, the process, the delivery, the pushing, everything went a lot smoother. Now, there's outliers, everybody has complications, but staying active has proven to be beneficial through the laboring process.
You mentioned Orange Theory Fitness. What about rowing in pregnancy and like the step-ups? Can they do that?
Step-ups, as long as they're not weighted, step-ups are fine, unless you're getting to that point of discomfort and fatigue. The rowers, you can modify, so if any of you row, you imagine how much hip flexion you get into in reaching. That doesn't necessarily preclude you as pregnant being able to row. You're just gonna have to modify your reach. You're still going through the same motion, because rowing is actually 75% legs, about 10% low back, and about 15% upper body. So as you're pulling through, your range of motion coming back is just going to be less as your belly gets bigger.
One insignificant one. Who came up with the idea of that little support band for the pregnant uterus?
I have no idea, but I want to thank that person.
I'd like to say, I wish I'd been that person.
Well, I found out, I started Googling. I was like, how to run while pregnant. And I did the one thing we tell our patients not to do, which is go on the internet and start finding answers. But I got very frustrated that every time I went to the OB, they were either telling me I shouldn't be doing what I'm doing, even though I was monitoring my heart rate, or they didn't even want to discuss what I was doing. And I mean, they made me ultrasound every time I went because of fetal growth, and it was always right on where I was supposed to be. And I'm like, listen, how am I doing more research than you are on this? So it's, as primary care providers especially, we deal with the whole patient. We deal with the patient through all aspects of their healthcare. Being able to put them at ease and stay active and say, it's okay to do this, it's good for you, it's good for the baby, is going to be important. But no, whoever created the belt, I want to thank them.
It's just such an interesting concept.
What is your recommendation for those women that are like big time CrossFit workouters?
CrossFit, you have to modify because of how much core work is involved with CrossFit. I generally, after 12 weeks, will say, hey, let's find something else that's similar, but maybe a little less from a strength training core stabilization. And then, you know, assuming they have a normal delivery, get back into it.
Hey, here we go.
Bless you. My patients who are pregnant are, generally speaking, type 2 diabetics that weigh 250 pounds and have not ever walked around the block. So when, you know, they're just busy. So yoga, Tai Chi, I mean, how do
Tell
you...
them to walk.
How do you start?
Walk. If it hurts, bike, stationary bike.
Stationary bike. Stationary bike. sounds
Stationary
like.
bike, because if you think about it, you're going to be off balance on a regular bike, and your risk of falling
right.
becomes too high. If you can talk to him, just get in the pool, walk in the pool
Walk in the
is a
pool.
great one in the shallow end.
Great. Sounds like a plan.
Oh, I had a question. Postpartum, when we have women who have diastasis of the muscles,
Then good.
what is the best way for them to exercise? Is there a specific? I've heard that if you do a lot of crunches, you're tightening the muscles, but you're not necessarily improving the separation. Is there a way that they can improve that, or is it just tightening the muscles?
Tightening the muscles.
Just tightening
Yeah.
the muscles. Okay.
Because
Thank you.
unfortunately, you're talking about that fascial tissue plane, and there's not anything exercise-wise that's going to pull fascia back together. So
Okay.
short
There-
of repairing it.
Okay. Thank you.
Is there any explanation why exercise would reduce postpartum depression?
Yes. Exercise, the correlation between exercise and physical activity and depression is the exact same correlation between postpartum depression and exercise and physical activity. So that same reason you want them moving prior to delivery, you're going to help combat and prevent that postpartum depression, at least from expelling. The increase in endorphins, the change in neuroreceptors, blood chemical makeup is the same response postpartum that you have during just a general major depressive disorder.
Okay.
What do you do if you have a couple who have planned to go mountain climbing, hiking, and then all of a sudden they find they're like 6 or 7 weeks pregnant? Should you encourage it, discourage it?
I would encourage it.
postpone
I would give them the information based on altitude studies, trying to stay below that 2,000 meters sea level if they're going to hike. And I would tell her, wear a heart rate monitor while you're hiking, take plenty of fluid from a hydration standpoint, take breaks. But hills, you know, I found personally when I was running, I had to walk up hills once I got to a certain gestational point, just because my heart rate would go up so high. So from a hiking standpoint, take breaks, let your heart rate recover, and just plan. It might take you a whole heck of a lot longer to get up and get back down than you anticipated or planned pre-pregnancy, but encourage them. They shouldn't have to stay at home and not move.
Couldn't you discourage them if they wanted to do like that free rock climbing?
Free rock
Where they
climbing?
use
No,
the
they
little
shouldn't be rock
fingers
climbing.
and-
No. Free rock climbing, that's a no-go.
That. You know, why can't I go?
I'm gonna go to the zoo and get one of the harnesses and
Would you do that?